24th webinar, and I take it a great privilege to welcome the speaker for the day, Dr. Wazim Mohammed, Associate Professor, Medical Director and Director of Research at the Division of Neurocritical Care, Department of Neurology, Associate Professor, Department of Neurosurgery, Program Director, Neurocritical Care Fellowship, Associate Program Director and Internship Director, Neurology Residency at the Wayne State University Detroit Medical Center. He's also the attending neurologist at the Detroit Receiving Hospital, consultant neurologist at the Detroit Medical Center, and consultant neurologist at the Barbara Ann Karmanos Cancer Institute. He's part of many professional societies, including the American Academy of Neurology, won many awards, including the Difference Maker Award at the Detroit Receiving Hospital and Outstanding Faculty Award at the university. He's member of many compelling decision-making committees. He's a journal reviewer of neurology, among many other international journals, editor board member in a number of journals, and played crucial roles in 21 clinical trials. With 17 international lectures and 13 research publications, apart from 7 case reports, 4 review articles, and 49 published abstracts under his belt, Wazim Mohammed is a doyen in the making. Dr. Wazim, it's a great honor, privilege to host you in this webinar. Welcome, Dr. Wazim Mohammed.
Thank you, Jacob. Thanks for the opportunity. Humbled to be here.
And to moderate our session and to take the session forward, we have our dynamic consultant neurologist at Believers Church Medical College and Hospital, Dr. Joban John. He's a consultant neurologist who has trained from the Trivandrum Medical College, and he has special interest in epilepsy and sleep neurology. He is an excellent clinician, and he is well known for his brilliant treatment. So, Dr. Joban John, sir, over to you for the moderation. I hand over to you.
Good evening, everybody. So today's topic will be status epilepticus seizing Pandora's box. As most of you know, it is many of the cases of status epilepticus are easily manageable with 1 or 2 lines of drugs. But at times we have cases which are very refractory, either refractory status epilepticus or super refractory cases, where there is no definite guidelines or definite evidence-based guidelines. So we have to go by the recommendations, and that vary from place to place. So I think Dr. Mohammed will throw a light into all the difficult issues regarding status epilepticus. And now the podium is yours, Dr. Mohammed. You can continue.
Thank you. And thank you again for this opportunity. I'm going to share my screen, and we should be set to go. Are you able to view my screen and hear me?
Yes, Dr.
Yes, we can see you.
Okay, all right. So one of my biggest disclosures over here is I'm not an epileptologist. I don't read EEGs. I'm a neurointensivist. So a lot of people question me at times, like, why am I talking about status epilepticus? It's a topic very dear to me, and I have a lot of interest in it, maybe because of the numbers that we see in our community, especially a lot of autoimmune encephalitis that we, presenting with status epilepticus that we see in our community over here. And I think that's paved the way for my interest. So what I'm going to try and do today is take you through the world of status epilepticus, maybe touch upon a few challenges, most of the challenges that we face, and also give you an idea about our treatment strategies, management strategies. A big key caveat to this talk is going to be that the numbers and statistics that I present over here may not hold true for communities across the world. It's our local communities numbers that I'm describing, but the basis and the approach may not be very different, even though the numbers might be. Having said that, these are my disclosures, just funding from a few clinical trials that I have. And this is what we'll try to go through today. We'll define what's status epilepticus, briefly touch upon epidemiology. Then we'll talk about the degrees of status epilepticus, basic diagnostic management, and like Dr. Jobin said, what are the guidelines? And that's why it's in parenthesis. It's not backed up by too much of evidence, and a lot of them are expert consensus. We'll go through first line, second line agents, and finally, I'd be happy to share some of the work that we've done over here in our population, some of the trials that we published. All right, moving on. So epilepsy, right? It's a word of Greek origin, derived from epilambenum, which means to take hold of or to seize. And that's where seizure, the word, comes from, which is a transient occurrence of signs or symptoms due to abnormal, excessive, or synchronous neuronal activity. I like to tell my residents and medical students that think of seizure as a symptom and epilepsy as the disease. You can go on treating the symptom, but unless you cure the disease or try to cure the disease, you may never completely treat the symptom. So if there is an underlying cause for the seizure, which is causing epilepsy, it might do justice to try and treat the underlying cause. The pathophysiological definition for status epilepticus may be very different from the clinical definition. So status epilepticus traditionally has been defined as seizure duration of 30 minutes or more. And the rationale for this is we have models of status epilepticus. This was published way back in 1990 that show that there is persistent neuronal damage after the 30 minutes. This graph shows the different parameters. And I don't know if you can see my cursor, but after generalized convulsions, the brain damage, what's documented is at least after 30 minutes. And over here, you can also see the brain parenchymal oxygen levels dropping after the 30 minutes of active convulsions. But we all know that we don't really wait for 30 minutes to start treating someone with status epilepticus. And hence the clinical and operational definition comes in, where more than 5 minutes of continuous seizure activity or multiple seizures without regaining consciousness in between or recovering to baseline is called status epilepticus. And the rationale for this is most clinical seizures should stop within less than 5 minutes. And if it's ongoing for more than 5 minutes, it's unlikely to stop on its own and will reach the 30-minute threshold where you have a permanent neuronal injury. And there's also some animal data that says that the permanent neuronal injury can occur way before 30 minutes. I'm going to just pause here for a second. As I was telling Jacob earlier, we don't necessarily need to wait till the end for questions. So if there are questions that come in between or while I'm talking, please feel free to ask me. So the International League Against Epilepsy actually came out with a definition for status epilepticus in 2015. So you can imagine the time that went on before they could actually define status epilepticus. But what they did was quite interesting. They defined status epilepticus as 2 time points, and they called this T1 and T2. Time point 1 is the time beyond which there are mechanisms that fail in the brain which should stop the seizure on its own, or there are mechanisms at time 1 that start up in the brain that will lead to a prolonged seizure. And that's what they defined as T1. And T2 is when there is irreversible injury or there's alterations in neuronal networks after prolonged seizures. So reviewing that again, T1 is the length of the seizure beyond which it does not really stop on its own and could need intervention to abate the seizure. And T2 is the time at which there is irreversible long-term consequences from the seizure. And as you can imagine, all seizures are not the same as far as T1 and T2 go. Different seizure semiologies have different classifications for T1 and T2, as this table over here shows. that T1 in a generalized convulsion is about 5 minutes, and at 30 minutes from the model that we saw earlier is when there's irreversible neuronal injury. Whereas focal status epilepticus, T1 is at about 10 minutes with 60 minutes being irreversible injury. Absence status, 10 to 15 minutes, and we really don't know what are the long-lasting effects and if there are long-lasting effects of absence seizures. Moving on. When you start seeing patients with status epilepticus, and this is based on ILE, that's International League Against Epilepsy recommendations, try to define status in terms of 4 axes. That's semiology, etiology, what are the EEG correlates, and age plays a huge role as far as etiology goes, or the cause goes. The semiology is broadly divided into status epilepticus with prominent motor symptoms and without prominent motor symptoms. Under prominent, you can have the convulsive, myoclonic, focal, tonic, or hyperkinetic status epilepticus. And without prominent symptoms is non-convulsive status epilepticus with coma, or non-convulsive status epilepticus without coma, which was, I think this was the class which was previously known as complex partial status epilepticus, and the terminology has shifted towards non-convulsive status epilepticus without coma. Based on etiology, they're broadly divided into known and unknown. We get a good amount of unknown etiologies over here. And known are acute, where patients with encephalitis or acute hemorrhages presenting in status epilepticus. Remote are long-term consequences of previous injury, which include previous ischemic strokes, previous TBI that present with late seizures, progressive disorders, and there are definite electroclinical syndromes as well. And unknown, like you say, you got to look for it. But a lot of times we don't find what the etiology is. So I'm not going to pretend like I can do a good explanation of this. There are way smarter people even on this call that can do EEG correlates, but broadly it's based on location, pattern, morphology, modulation, and effect of intervention that you classify the status based on EEG. And finally, age, because there's a very dramatic difference in the etiologies based on the age of the patient. And most of my talk is going to be geared towards adulthood and elderly. And none of the data that I'm showing over here is in the pediatric population. So this classifies the etiology of the status based on age. As you can see, at early ages, cerebral malformations make up the big chunk. And as you grow older, in your middle age, head traumas become a big cause. And as you grow even older, ischemic strokes or any forms of stroke take up the majority of etiologies for status epilepticus. All right, so coming now to the intensity of status epilepticus based on how intense the seizures are or how long they last. We've defined status epilepticus as a clinical seizure that lasts for greater than 5 minutes or recurrent seizures without coming back to your baseline. And we get to established status epilepticus. That is status epilepticus that persists after adequate treatment with a benzodiazepine, which is a first-line agent. More on that later. Then we have refractory status epilepticus, that's status epilepticus that persists after an adequate dose of a benzodiazepine, followed by a second AED or second-line agent. Refractory status occurs in about 25 to 50 is probably a little high, but more on the 25 to 35% of patients who present with status epilepticus. And we have super refractory status epilepticus, which is a world on its own, where seizures last for greater than 24 hours with use of anesthetic therapy, or you have the patient on IV anesthetics And once you wean the patient off the IV anesthetic, status epilepticus recurs, and that's a super refractory status epilepticus. And it can occur in about 20% of the patients who come in with status epilepticus. I'm not sure, Dr. Jacob, are these frequent cases that you see in your community as well, super refractory and refractory status?
We see cases of refractory. Super refractory is not that common, but refractory cases we do come across in the hospital.
Okay.
Most of them are controlled with one or maximum of 2 agents, most of them.
Do you have a protocol in place on how refractory and super refractory are treated, or is it based on clinical judgment or patient to patient?
Mostly we have the ILA guidelines we follow in most of the cases. Some differences may be there, the treatment based on from patient to patient. There may be some variation, but usually we follow the protocol which has been devised by the ILA.
Yeah, I think that's where even our institute, I think we have for established status, we have pretty much guidelines and protocols. When it comes to refractory and super refractory status, the protocols widely vary from institute to institute. All right, so going on to some of the epidemiological stuff, mortality associated with convulsive status epilepticus. Usually at about discharge, it's about 9 to 20%. At 30 days, another 30%. At 90 days, another 20%. And in non-convulsive status epilepticus, you'll see that the mortality rates are much higher. And I think the reason for this is that it's underdiagnosed and misdiagnosed. So the patients continue to have seizures and status epilepticus that persist for a really long time before they receive adequate treatment, and some of them don't even get adequate treatment. Once it comes to refractory status epilepticus, the mortality rates are obviously much higher. Some of this might even be because of iatrogenic stuff that we do, such as intubations and IV anesthetic agents. And there's always been the debate of are IV anesthetic the best modalities to treat these patients? Is intubation the best modality to treat these patients? And we don't know, and all we can do now is follow consensus statements. So what are the factors that determine mortality after status epilepticus? Age obviously plays a big role, and this is old data, but I think it still holds true. The older you are, the higher chance of mortality. The duration of seizure continues to hold true. So the blue line over here is the survival. Survival is on the y-axis and the number of days on the x-axis, where if you have a seizure that's longer than 1 hour, as the days go by, the percentage of survival goes down. And etiology also plays a major role of what the outcomes are. Idiopathic status epilepticus has a higher mortality because there is no underlying cause that you identify that you can treat, and these patients tend to be more refractory and more super refractory. Patients who present with non-compliance or low anti-epileptic drugs, they seem to have a more favorable profile because it seems like it's an easier population to treat. Hypoxia and anoxia, post-cardiac arrest myoclonus specifically, very high mortalities. And again, an area that we don't know much about and how to treat these patients. So their mortalities are extremely high. As far as morbidity goes, there's convulsive status epilepticus and refractory status epilepticus. Basically, a lot of morbidity associated with it. There's deterioration in functional status in a quarter of the patients, and majority of them will have not be able to return to, not a majority, a lot of them will not be able to return to baseline. And some percentage of them will have neurological sequelae that persist for a long time. So this is, we did this in our institute, and we looked at the predictors of outcome in patients with status epilepticus. This was a cohort of about 100 patients that we looked at what are the outcome predictors. And we divided them into good outcome and bad outcome based on the Glasgow outcome scale at discharge. Now, we don't have long-term follow-up on these patients, so That's one of the limitations over here. This was at discharge. We saw that patients who were in refractory status epilepticus or initially presenting with complex partial, which is now non-convulsive status without coma, or if they had non-convulsive status epilepticus at any time, then they had worse outcomes. And based on this, we looked at before that, as you can see, history of epilepsy actually had a favorable outcome, and it was because most of these patients came in with either low or undetectable anti-epileptic drug levels. So based on this, we created a model to look at who are the patients that are going into or will progress to non-convulsive status epilepticus. And we found that patients who had presented with complex partial status epilepticus, patients who had refractory status and inverse relation to history of epilepsy, modeled pretty good for the predictors of those who may go into non-convulsive status epilepticus with a AUC of area under the curve of 0.81. And those were the corresponding p-values. There are many scoring systems for status epilepticus. Personally, I don't find this useful for clinical management. It's extremely useful for research endeavors. It's extremely useful to classify how sick these patients are and for retrospective reviews. But prospectively going forward, I don't find this very useful, because when I'm treating a patient with status, I'm treating a patient with status, and irrespective of what the mortality may be, I go ahead and treat based on protocol. However, it may also be useful in at times in communicating to families or telling them what to expect in patients presenting in status. So you have the test score, and on the right are graphs that look at the prediction of mortality. So you have the test score with various components. Then you have the EMS test score, which takes the test score and combines modified Rankin scale prior to admission into that. And as you can see, the more complex the scoring system is, the better the ROC curve. But a lot of times this may not even be practical or reproducible. And then the ended score is taking encephalitis. So it's important to know that there are scoring systems out there, and see if it's useful or not. It's up to individual preference. So patient's been diagnosed, is in the ER, and then what's the diagnostic workup we do? All of these patients should get at least all the points over here. They need to be evaluated for their blood sugars, evaluated for the need for a head CT. Patients presenting with low AED levels with a history of epilepsy, non-compliance, may not always need a CT scan on every admission. Other lab tests, including AED levels, and consider continuous EEG monitoring if at all possible and if available. And based on presentation, you may want to consider an MRI, lumbar puncture, other toxic panels which may provoke status epilepticus, and other lab tests as well. It's very important to assess the patients who may need additional workup. And actually, I was giving this talk before, and one of my colleagues, Dr. Marawar, I don't know if he's on the call over here, he asked a very important question: is how much do you look and who do you look in? And I was pretty dumbfounded. I don't have the answer to that, and I don't know if anybody knows how extensively do you look, because a lot of times you don't end up with etiology. All right, moving on to, I can pause over here. Do we have any questions, or shall we keep moving? Okay, I think we can keep moving on. So management, right? And this is the ILAE proposed algorithm for management of status epilepticus. The font is a little small over here, but we'll go through individual sections. But what I've tried to show here is it's divided based on the intensity of status into 4 tiers. And the first phase is called the stabilization phase, where you're not quite into the diagnosis of status epilepticus, because remember, we talked about before, it's greater than 5 minutes is when the diagnosis of status epilepticus is made. So in the stabilization phase, the treatment approach is supportive. Initial therapy, which is the 5 to 20 minute phase where you give first line agents. Now you have established status epilepticus and you give second line agents where the time frame is about 20 to 40. And lastly, refractory status epilepticus where you institute third line agents. And as I said before, we'll go through these sections individually. The first 0 to 5 minutes is supportive care, where you stabilize the patient, always ABCs, airway, breathing, circulation. You monitor oxygenation, you get an EKG. We have a pretty good population who are malnourished or who have alcohol abuse. So in patients with low blood sugars, we always ensure that thiamine is given before any dextrose solution. There have been a few cases that have been precipitated to Wernicke's encephalopathy by giving dextrose prior to thiamine. And establish your IVs. Get ready for the next phase in the treatment of status epilepticus, in the next phase of seizures, which is status epilepticus. Get 2 peripheral IVs, get good access, 18, 20 gauges that are working well, because very soon you might be infusing a lot of drugs through those IVs. So the initial therapy where you have a diagnosis of status epilepticus, and this should be completed in within about 20 minutes. Management is first line agents. And I cannot emphasize this enough that a benzodiazepine is always the initial therapy of choice. I sound like a broken record to my residents and the med students that are with me because I emphasize this over and over again. A benzodiazepine is always the initial therapy of choice. And we'll talk about the dosings in a minute. But the benzodiazepines available to us are midazolam, lorazepam, or diazepam. At our institute, at least, we don't use diazepam as much. We use a lot of midazolam and lorazepam. And the benzodiazepine equivalents are 1 milligram of lorazepam is 2 milligrams of midazolam, which is 5 milligrams of diazepam. So before we go into the dosing regimens for the first line agents, I want to briefly talk about the Rampart study. This was published in 2012, and we were a center that participated in the study. And this was a pre-hospital study that compared midazolam to lorazepam. IM, intramuscular midazolam, to intravenous lorazepam, and they looked at the efficacy and safety. And this was the dosing regimen, 10 milligrams of midazolam or 4 milligrams of IV lorazepam. And they saw that it was safe and as effective. So midazolam was as safe and as effective as IV lorazepam for pre-hospital seizure cessation. Another interesting take-home point from the study was higher doses of benzodiazepines may actually reduce the number of airway interventions that are required, and that endotracheal intubation was more commonly as a result of ongoing seizures and status epilepticus as opposed to sedation from benzodiazepine. And this is a very important message, especially to our ER colleagues, where there's always a hesitancy to give adequate benzodiazepines, thinking that they may require an airway intervention or intubation. But as you can see from here, there were more airway interventions and intubation from ongoing seizures rather than overdosing with benzodiazepines. And that's where our recommendations come from regarding dosage is 0.1 milligram per kilogram with a max of 4 milligram per dose. And you can repeat the dose once in about 5 to 10 minutes if the seizures have not stopped. So in most adults, at least, rarely do you find someone less than 40 kilograms. So all you have to remember is if the patient is in status epilepticus, I need to give 4 milligrams of intravenous lorazepam. And based on this, we looked at our data on how much benzodiazepines we are giving patients with status epilepticus. This was presented at AAN, and I think we published this later as well. And what we saw was the median lorazepam dose that our patients were getting were 3 milligrams. So this would mean that the average patient presenting was 30 kilograms, which is impossible in our community. And we also saw that only 31% of the patients received adequate benzodiazepine dosing. And non-convulsive status epilepticus was much more common when benzodiazepines were not given at adequate dosage. And among patients who progressed to refractory status, 75% of those patients did not get adequate benzodiazepines. We also saw that the cumulative incidence of status epilepticus inversely correlated with a benzodiazepine dose, which means the higher the amount of benzodiazepines you give, the less cumulative incidence of non-convulsive status epilepticus. These were additional findings which did not reach statistical significance in our study. The mean ventilatory days seemed to be lower in patients with adequate benzodiazepines, and also less percentages of poor outcome. They did not reach statistical significance, I think, based on the numbers. And this was the graph that I was talking about, showing decreased incidence of cumulative incidence of status epilepticus with escalating doses of benzodiazepine. All right, that's our first line therapy when the diagnosis is status epilepticus. Moving on to established status epilepticus, we are at the 20-minute mark now, where seizures are ongoing, and we have to give a second-line agent. And the choices that you have are phenytoin or fosphenytoin. Our institute still uses phenytoin, even though widely the recommendations are for fosphenytoin. That's a whole different conversation to get into. But the recommendations are fosphenytoin or valproic acid or levetiracetam. And for a long time, we were underdosing fosphenytoin or phenytoin and levetiracetam. The guidelines say the loading dose for phenytoin is 20 milligram per kilogram. Valproic acid is 40 milligram per kilogram. And levetiracetam is 60 milligram per kilogram. For valproic acid, all of them have max doses as well, 1500, 3 grams, or 4500. But it's important to adequately dose patients with a second-line agent if it reaches that stage. This was the established status epilepticus treatment trial. We were part of the study as well, where they compared fosphenytoin to levetiracetam to valproic acid in a 1:1:1 randomized fashion. And the primary outcome was clinical cessation of seizures at 60 minutes. And the secondary outcomes included safety. This was a multi-center trial in kids and adults. The adult part was where we were involved, and these were the doses that looked at it. And I think that's where the recommendations came from the ILAE is 20, 40, and 60 of fosphenytoin, valproic acid, and levetiracetam. Results of the study were that treatment was successful, equally efficacious among all 3 agents, and about 50% of the patients responded to first-line agents. We've looked at our data as well. What is the comparative efficacy of anti-epileptic drugs at our institute? And what we saw that patients with status epilepticus, established status epilepticus, at least received 1 anti-epileptic drug. Most commonly used were phenytoin, levetiracetam, and lacosamide. And as a first AED, no one agent was superior to another. 79% of the patients received a second AED, at which point the termination rates were about 65%. And what, at least in our local cohort, what we saw was phenytoin as a second AED was superior to other AEDs. And 39% of the patients received a third AED, at which point the termination rates were much higher, getting up to 84%. And again, as a third AED, no single drug was superior. And there was a tendency, or there was a signal that levetiracetam and phenytoin combination had a better success rate than other combinations. And like I was saying, in the first AED, there was no difference. As a second AED, phenytoin seemed to be a little superior to the others. And as a combination, the combination of phenytoin and levetiracetam had the best efficacy compared to other combinations. Okay, moving on to another drug we commonly use, we use a lot, is Clobazam. Clobazam is a little different from a traditional, the 1,4-benzodiazepine. With regards to its anticonvulsant receptor selectivity, it upregulates GABA transporters to the synapse. It's rapidly absorbed with great bioavailability. It's got great tolerability, and peak plasma levels are reached within 1 to 4 hours of oral administration. And there are few drug-drug interactions. All of this making clobazam a favorable medication to consider, even though it's not listed as one of the second-line agents in status epilepticus. And if you have to move on to another agent, this might be a viable option. And this is data from our institute again, where we published the efficacy of clobazam in refractory status epilepticus. This was a retrospective review over 2 years, and we looked at all patients. How we got the patient cohort was we got all the patients that were prescribed clobazam, because that was probably the only indication for clobazam at our institute. And we categorized the response to status epilepticus or refractory status epilepticus as successful, indeterminate, or unsuccessful. They were deemed successful if clobazam was the last medication that was added and there was termination or cessation of seizures within 24 hours. It was considered indeterminate if there was another drug added to clobazam and there was cessation of seizures within 24 hours, or unsuccessful if other drugs had to be added on after clobazam. We identified 17 patients, and those were included in our study. This is the breakdown: predominantly male African-Americans, focal epilepsy in a lot of them. The important thing was that the majority of these patients received benzodiazepine, adequate benzodiazepine, because you could always, if clobazam turned out to be efficacious, you could say, all right, the patient did not receive adequate benzodiazepine, and that's why you give more benzodiazepines, and that's why the seizures responded. But it was good to know that in this patient population, at least, they received adequate benzodiazepines prior to administration of clobazam. And this was the breakdown of what order it was given in. It was the earliest it was used was as a third anti-epileptic drug, and then so on and so forth. And in 94% of the cases, it was the last medication given. So over here, you can already start seeing a signal that in 94% of the patients, if it was the last drug given, that means their epilepsy or seizures may have resolved after that. And that's what the results show, that 76.5% of those patients had a successful termination of refractory status after administration of clobazam. About 17% had indeterminate, and only one patient failed. We see this is an extreme of results over here, and I don't think this will hold true in larger population and larger cohorts. But I think this was very encouraging for us and paved the way for us to use this a lot more. It was the mean duration where it was introduced was at 4 days after 3 AEDs were failed. Sedation was a side effect, and at about 30 to 40% of the patients had sedation as a side effect, which later on caused us to lower the dose of clobazam. The mean starting dose was about 10 milligrams per day, and maintenance was about 20 milligrams per day, fractionated dosing twice a day, so 10 twice a day. All right, okay, I think we're actually maybe running short of time, so I'll move a little faster. Third line therapy is when you call this refractory status epilepticus. We're at about 40 to 60 minutes now. And again, there's no consensus of one agent being superior to another, and your options are midazolam, propofol, or pentobarbital. In the United States, we don't have thiopental, and I know Carpenter is used around Europe. Even pentobarb, I haven't used in a while. It's mostly midazolam and propofol. And these are the dosing guidelines for anesthetic agents. Midazolam, you start at about 0.1 mg per kg per hour or 0.2. Go out, recommendations say you can go up to 2 mg per kg per hour, but I haven't really seen much benefit once you get to about 1 milligram per kilogram per hour. Propofol started about 20 mics per kilo per minute. Recommendations say you can go up to 150 mics per kilo per minute. 200 mics per kilo per minute. Our institute starts questioning us once we go over 50. They still allow us to use it, but there would be attending sign-off that's required when you start using it over 50 mics per kilo per minute. And we really don't see propofol infusion syndrome in adults as much as kids. I'm not sure what the pediatric experience has been, but in our adult population, at least, I think I've seen maybe one patient with propofol infusion syndrome in the last 10 years. Briefly talking about what the synapse does during a seizure. So this is a patient without a seizure. You have extrasynaptic GABA receptors and you have intrasynaptic GABA receptors. And after the 10th seizure, there is internalization of these GABA receptors, forming vesicles, which are eventually removed by the lysozymes. So one can expect that if you have ongoing seizures, there aren't as many GABA receptors in the synapse. So benzodiazepines may not work really effectively. And as opposed to NMDA receptors at the control unit, there aren't as many NMDA receptors. But after the 10th seizure or ongoing seizures, there's upregulation of NMDA receptors at the synapse. And this is called trafficking, where there is an increase in the NMDA receptors in the synapse and a decrease in the GABA receptors. And the increase in the NMDA receptors causes hyperexcitability, neuronal hyperexcitability, which goes in hand with the development of refractory status epilepticus. So obviously, based on that, a potential target would be an anti-NMDA medication. And that's where ketamine has started making its entrance into the world, not entrance, has become a point of interest for status epilepticus. This is from our critical care EEG monitoring consortium that our institute is part of. And they looked at a multi-center review of ketamine use in refractory status epilepticus. What they saw was that ketamine was likely responsible for status epilepticus control in about 12% and possibly responsible for control in an additional 20%. Now remember, these numbers may seem small to you, but these are very sick patients who have ongoing seizures despite benzodiazepine, anti-epileptic drugs, and first-line anesthetic agents. So at that point, having something that can give additional control might be useful. I think there's a question in the chat box. Oh, sorry, you can disregard that. Thank you though for the compliment. So likely response was not observed when the milligram per kilogram per hour was less than 1, and failure was noticed when the ketamine was introduced greater than 8 days after status epilepticus or after failure of 7 or more drugs. And response was highest risk when ketamine was introduced early. And as the third or fourth agent, it had about 60% success. And like I said earlier, there was no response when it was introduced greater than 1 week, after 1 week, or after 6 or more drugs had failed. This is, again, from our institute. I don't know if Mesa is here or Dr. Shah is on the call, but this was a retrospective review of status epilepticus patients who got treated with ketamine. And what they found was very interesting. Ketamine was successful in 30 patients, but all the patients that it was successful in after starting, they had a characteristic EEG pattern, which was a frontally predominant archiform theta to beta rhythm. And this rhythm was seen with both low and high doses of ketamine, regardless of other anesthetics. And the appearance of ketamine EEG effect was within minutes to hours after starting the ketamine. So it had a good, proved to be a good predictor of who are the patients who may respond to ketamine and who may have success with ketamine in the treatment of refractory status epilepticus. This is another project that we are doing right now. It's very early in its infancy, so I don't have many patients. And the thought over here was how can we use ketamine in refractory status epilepticus to avoid intubation? Because like we were talking about earlier, some of these things that we do to our patients may actually be more harmful than helpful. I don't know who are the patients it might be more harmful than helpful. Intubation, long-term IV anesthetics, side effects from the anesthetics, use of vasopressors. So if there's a role to prevent intubation, it might be desirable. And ketamine does not cause the respiratory depression like other anesthetic agents. You have to be careful though, because ketamine has a potent cholinergic action, so increased secretions and airway interventions might be needed, and you might be able to get away. So we had 6 patients where ketamine was used as the first anesthetic agent, and we assessed whether they would prevent intubation. Most common etiology for the refractory status was post-stroke epilepsy. We gave adequate benzodiazepines to all of them. 4 out of the 6 patients had successful cessation with ketamine alone. These were the doses. Median max dose was about 2.1. One patient had excessive secretion but was not intubated. One patient developed fluid responsive hypotension. Overall, only in 2 patients did we avoid intubation. 2 others among the success still had to be intubated, and 2 others failed ketamine. There might be some interest over here. I'm not sure if Dr. Zucchi, she's a co-investigator with me in the trial, if she's on here. But if she's on here.
I'm here.
Do you have any comments on this, or how we should move forward with this?
I think, I read the EEG part of this. So I think that, this is still kind of new, but it's definitely something promising, and it's worthwhile, and you have to select the right patients is the main key thing here.
Okay, so hopefully, we can come back to you guys at a later time with more data if this keeps going on. Briefly touch on this. This is a topic on its own, autoimmune encephalitis, and this is what we talked about, trying to target the disease rather than just the seizures. We tried plasma exchange, usual dose about 5 cycles, IV steroids, usual regimen is about 1 gram daily for 5 days, IVIG, traditional dosing that we use for other Guillain-Barré and other autoimmune conditions. And I think there are patients that we've put on cyclophosphamide and rituximab. There's at least a couple of, one NMDA patient that I remember and one GAD patient that I remember that were put on cyclophosphamide and rituximab. This is also from our institute. This was published, I think, back in 2017. And for very super refractory patients, they're on multiple anesthetic agents, multiple anti-epileptic drugs. And every time you wean the anesthetic off, they continue to fail and they go back into status. So our group over here, they looked at doing resective surgery to cure status epilepticus. It was about a case series of about 9 patients. 8 out of the 9 patients survived to discharge. 6 patients had resolution of refractory status within 48 hours of the surgery, and 5 patients were seizure-free at the last follow-up. And they proposed this algorithm on who are the candidates that might benefit from resective surgery. To summarize this, patients who had a focal MRI or PET scan with a lesion that could be resectable, and the seizures came from that lesion, and had failed medical therapy. Those were the patients who might have been candidates for resective surgery. Actually, I'm going to take a minute here. Somehow we don't see these patients anymore, the ones that are candidates for resective surgery. I'm not sure why. Is it because that the disease burden has decreased, or have we become more efficient in treating this? Actually, if Rohit or Mesa, if either of you are here, what do you think? Why don't we see these patients as much anymore? Okay, they might not be on. Deepti, anybody else from our DU?
Hi, this is Shishir. One aspect that I can think of is we're more proactive with adding more and more medications, and at some point we have been successful with stopping the status. We've gone to 6-7 medications as well, and we're more proactive with starting anesthetic agents early, and ketamine, like you mentioned. So that could be the reason. And since I've joined, I haven't seen anyone that we have not been able to stop status by just adding all the medications.
Okay. All right, moving on. Okay, the last part of our lecture is super refractory status epilepticus. And this, like we've talked about earlier, status epilepticus that lasts for 24 hours or longer on IV anesthetic agents, or status epilepticus that recurs on withdrawal of IV anesthetic agents. And this is the time course that's been splayed out over here about progression from seizures to super refractory status epilepticus. And neuroactive steroids have become an area of interest in super refractory status epilepticus. So we talked about the Gaba receptors earlier, and there are synaptic and extrasynaptic Gaba receptors, and traditional benzodiazepines don't really act on the extrasynaptic GABA and only the synaptic GABA receptors. As seizures continue and are ongoing, the synaptic GABA receptors are downregulated, but the extrasynaptic GABA receptors remain. So that makes them a potential target for neuroactive steroids. And various forms of allopregnanolone is what's been studied and is going to be studied. So this was the Sage 547 trial. We were a center. This was a multi-center, multi-country, multi-continent trial, which looked at the efficacy of brexanolone for the treatment of super refractory status epilepticus. The compound at that time was Sage 547. And their endpoint was you give the patient IV anesthetics, you give the patient the brexanolone, and then see if you can wean the IV anesthetic agents without successfully without the seizures recurring. And this is their endpoints. So endpoint 1 and endpoint 2. Endpoint 1 is if you could wean off the IV anesthetic agents during the Sage 547 infusion. Endpoint 2 was if you could wean off the anesthetics prior to Sage 547 taper. And you'll see, at least in the phase 1 and phase 2 studies, the success rates were very good. 17 out of 22 patients and 16 out of 22 patients met successful endpoints for successful weaning of third-line agents. However, unfortunately, whatever happens in phase 1 and phase 2 doesn't necessarily pan out when you get to a phase 3 study. And this was the results of the intention to treat population. And you can see there was no significant difference between placebo or brexanolone in effectiveness of weaning off third-line agents. And this was there was a signal over here. If the cause for epilepsy was structural, then brexanolone may have a role, but none of these reached statistical significance as in weaning off third-line agents. But because there's still a lot of interest in neurosteroids, and there is belief that it may play a role. So this is an ongoing study that we are embarking on right now. It's using a different compound, IV ganaxolone, which is again a neuroactive steroid. It's a synthetic analog of allopregnanolone again for treatment of refractory status epilepticus. Again, ganaxolone acts on GABA A receptors, both intrasynaptic and extrasynaptic. And what they're looking for in this population is that refractory status epilepticus patients and not super refractory status epilepticus patients. And that their thought process from the SAGE 547 study was maybe that the population that they targeted were too sick and may have not been the right population to target, and that's why the study failed. So in ganaxolone, they're targeting refractory status epilepticus patients, and their endpoint is to see if you can prevent the administration of IV anesthetics in these patients. Obviously, the goals, the dosing and all that is also different, but the main differences from the SAGE trial are the population, that's the refractory status epilepticus as opposed to super refractory, and if they can prevent progression to IV anesthetics as opposed to being off IV anesthetics. So Dr. Rao, who just spoke, he's the site PI on this. Shishir, do you have anything to add, or what's your thoughts on this trial?
Yeah, I think one of the major difference is at what point they're going to intervene between the two studies. The ganaxolone is a little earlier, so that they're hoping to get better response in these patients than super refractory, like Dr. Mohammed mentioned, which are harder to control anyway. And the drug dosing is also significantly different between the two studies. I think those are the main differences between the two studies. So we're hoping to get these results sometime.
All right, excellent. Okay, I think that concludes it. So take-home messages are, you want to differentiate status epilepticus from established status epilepticus, refractory status and super refractory status. Adequate dosing of benzodiazepines. If you don't start off well, you're not going to achieve success and you're going to be circling the drain for a long time. So adequately benzodiazepine dose these patients. Effective dosing for second-line agents, including phenytoin, levetiracetam, and valproic acid. Consider clobazam for refractory status epilepticus. Adequately dose anesthetic agents if you're going to use them. If you're going to use ketamine, use it early. Don't wait too long to use it. In very refractory or super refractory cases, think of autoimmune encephalitis as a cause for new onset refractory status. If there's a focal lesion that's amenable to surgery in patients with failed medical therapy, consider resective surgery. And I think that's it. Obviously, none of the stuff that I presented here or the stuff that we're doing would not have been possible without my colleagues, our pharmacists and research coordinators. There's a lot of hard work going in every day to treat these patients, and we're very proud of the work that we do over here. I'll end right now and happy to take questions.
Thank you, Dr. Wasim. It was a comprehensive and expert talk on, especially on the practical aspects of managing status epilepticus. Some of the points which I would like to repeat from your talk are the inadequate use of the benzodiazepine. That is a true thing, because we tend to jump to the second line agents like phenytoin or valproate before giving adequate trial of benzodiazepines. That is a truth. And again, ketamine also appears to be a promising agent, because when we go into phenobarbital or higher doses of midazolam or other IV anesthetic agent, we invariably have to intubate them, and we face all the complications related to intubation and also the anesthetic agent. Maybe we are not much familiar with the usage of ketamine, but maybe in the future it may save us from intubating the patient. So it results in extra days in the ICU and the cost factor also. And regarding questions, I myself will ask a question initially. So in your experience or in your center, after a benzodiazepine has failed, that means IV lorazepam or midazolam in the year has failed, which one do you prefer? Is it phenytoin or levetiracetam or sodium valproate or even lacosamide? Which is the agent, as per your personal experience, which will you prefer?
So among the three that you mentioned, as you know, lacosamide is not in the guidelines as first-line agent. I think it will make it there, but right now it's not in the guidelines, so I don't use lacosamide as second line agent. I have a personal preference for phenytoin, but a lot of times by the time I'm called to see the patient, the ER has already given the patient levetiracetam. If that's the case, then I continue the levetiracetam as opposed to stopping it. If I'm called, I have a bias towards phenytoin, even though I know my colleagues don't like it as much, but my go-to is phenytoin a lot of times.
Okay, another. I would request the all the participants who are seeing this to post the questions in the chat box. In the meanwhile, I will continue asking. So regarding you were talking about the difference between phenytoin and phosphenotoin because of the thrombophlebitic issue with thrombophlebitis and the ability to give it faster. We prefer phosphenotoin.
No, absolutely. If you have it, no. If you have it, you should use phosphenotoin. We are been grappling with our administration and pharmacy to switch from phenytoin to phosphenotoin. But what some of the arguments that they pose is they haven't had a single incidence of purple glove syndrome at our institute since I think 1980s or since when they've been using phenytoin. Number two is obviously expense related. And like I said, I might be one of the few people who are still using phenytoin as opposed to most of my colleagues using other agents. So they don't really see a need to change from phenytoin to phosphenotoin. But absolutely, you should be using phosphenotoin if you have access to it.
Okay. And again, in your experience or in your opinion, when should we be adding clobazam? Because somewhere in the literature I have learned that it is effective in 10% of patients only and may not be in others. So whatever it may be, in your experience, when do you think we should introduce clobazam? Means we have given an IV benzodiazepine, then you have given phenytoin or one of the other second line agent. And where in between these protocol should you believe we should introduce clobazam, because it's a relatively safe drug and people tend to use it very easily. So if we can introduce it early on, what is your take on that?
So my approach, and I think the institutional approach as well, is you give a benzodiazepine, patient continues to have seizures. You give first line AED and the patient fails. We may try another AED and that fails. At that point, I would seriously start considering clobazam as the third anti-epileptic drug. I know there's a variation in practice. Actually, I just see one of my colleagues over here, Dr. Khwaja, he's a neurointensivist with me. I asked, do you have any thoughts on this? I know Shishir and I might be biased because we trained for residency at the same place on the use of clobazam. What is your approach, or what do you think about introducing clobazam?
Absolutely. I think it's a pretty good option. I haven't used it much in residency, but in fellowship, I have used it as more of a third or fourth line agent in addition to the more usual recommended agents, and have had decent success with it as long as you introduce it relatively early and at a dose that's more appropriate to treat refractory status epilepticus. So I think it's a pretty reasonable and good option. Especially stopping short of needing to rely on phenobarbital. In place of phenobarbital, the clobazam is pretty, is a better option in my opinion.
Yeah. And again, regarding the maximum dose you could go to, or?
Yeah, I think I've used up to 10 milligrams. Actually, we used up to 20 milligrams twice a day.
So up to 40.
Yeah, but if you're getting to 20 and you're not seeing much, 20 milligrams a day and not seeing much, it's probably unlikely. So if you go from 8 seizures to 2 seizures, that's a pretty good effect. So there might be some role to go up even more. But if you're going from 8 seizures to 7 seizures, 20 milligrams, you might not have much of a role to go even beyond that. But it's easily orally administered. And always think of status epilepticus as a different disease from long-term epilepsy. So clobazam will stop the status epilepticus. There's always chances to wean off in the future or switch to another more tolerable medications. But I think for the status population, at least it works really well.
And again, a difficult thing that we experience. So what is of course, it is based on the EEG findings. So do we have any take on how much time we should wait before we start tapering the thiopentone or propofol or all those IV anesthetic agents?
So there are two parts to that. Are you using thiopental? We don't have access to thiopental over here.
We have thiopentone here.
Okay. Yeah, I don't have much experience with thiopental because we don't have it here. I have experience with propofol and propofol and midazolam. So approach is at least how long do you keep them on the anesthetic and how quickly do you wean off the anesthetics? Those are two different points. What our approach is at least 24 hours seizure-free on IV anesthetic agents. Now, there are different approaches to it. Some people say that you need to aim for burst suppression on the EEG, and some people advocate for just seizure control. And there's no good data of one being better than the other. It's probably easier to achieve burst suppression because you can look at the EEG screen and clearly say that this is burst suppression. And as opposed to seizure suppression, which may require a lot more review of the EEG patterns to see if seizures have been controlled or not. So there's no wrong answer to that. You can either target seizure control or achieve burst suppression. We know that flatlining is not good. So recommendations have been made to not flatline the EEG. We keep them like that for 24 hours. And then there are two schools of thought again, quick wean versus a gradual slow wean. What we seen from the Sage 547 study, and even though it's not been published extensively yet, is there was really no difference between weaning quickly and weaning gradually. So a quick wean in less than 24 hours, or even quicker than that at times, may not be very different from a very slow gradual wean. And at times, when you're weaning off the IV anesthetics, the EEG patterns start looking very malignant. And you're almost definite that, okay, this is going to go back into status. But you'd be surprised that the EEGs calm down after you wean off the IV anesthetics without the patient going back into these malignant status patterns.
So one more question before we wrap up. With those with hemodynamic instability, those midazolam and propofol are known to reduce the blood pressure, which will be the agent of IV anesthetic of choice, other than ketamine.
Sorry, you broke up. Go ahead.
If the patient has a hemodynamic compromise, means his blood pressure is coming down, so we will not be able to use midazolam or propofol. Then what would be the IV anesthetic agent which you choose in patients who are hemodynamically unstable?
Yeah, so we don't have too many options, right? So it's either midazolam, propofol, or ketamine. And again, the guidelines don't advocate ketamine as the first anesthetic agent if the patient's intubated. So on those patients, we start vasopressors and put them on IV anesthetics. So we don't hold off on IV anesthetics because the patient is hemodynamically unstable. We start them preemptively on vasopressors and put them on IV anesthetics.
Okay, Dr. Wasim, thanks once again. I think I will hand over to our host, Dr. Jacob, for further proceedings.
Dr. Wasim, thank you so much. That was an amazing presentation. Though I did understand a few of it, but I was really glued to the session, and thank you so much. We are really grateful that you came over and gave this session on our platform. Just curious, from your current slide, why is it that it reads the nation's best nurses work here?
Oh, that's so there's a ranking system where there are awards given to hospitals based on nursing performance quality measures, and they say they give an award, and this is the banner that they put up at Detroit Receiving. So that's my hospital, Detroit Receiving Hospital. It's a level 1 trauma center, and it's also a primary stroke center, and we have our own closed neuro ICU over there. And on the right is our neurotrauma unit where I work at.
It looks very much like you're all family. It's a beautiful picture.
Yeah, we're very close, and we spend a lot of time over there, so you have to be.
Wonderful, wonderful, wonderful. Yeah. So thank you so much, Dr. Wazim. It was a great pleasure having you. We would love to have more sessions from you down the lane. And thank you. Thanks again.
Yeah, thank you for having me. It was a wonderful opportunity and pleasure to present. Have a good day.
Yeah, and I would like to thank our moderator also, Dr. Joban sir, for coming over and moderating this session quite admirably. And we did get a lot of take-home points for us, and I think it will augur well for our department as well. And thanks to all the participants. We've got participants from all over the world here, and it's a great privilege to have you all here. We do have sessions twice a week, and you can follow the flyers on LinkedIn, or you can just write to drrsjj@gmail.com. drrsjj@gmail.com. We can send you the flyers, and we have a faculty from all over the world talking on our platform. We are working really hard on that, and I would like to register that we are probably one of the very few medical colleges who are currently involved in such an initiative. We would love to continue, and we would love to have your support also on this. So on that note, thank you all once again, and let's wrap up this session, and we will meet again on the 30th. On the 30th, we have two sessions. One is a cardiology session, and another is an ophthalmology session. The cardiology session is a senior cardiologist from the United States of America, and the ophthalmology session is a friend from NHS UK. So if any one of you would like to have the flyers, please write to us. So on that note, we would sign off for now. Thank you so much, everybody. Special thanks again to Dr. Wazim Muhammad and the moderator, Dr. Joban sir, and all the participants. Have a blessed evening. Thank you.